So good evening, everyone, and a very warm welcome to you all for tonight's Actuarial Research Centre sessional research meeting entitled How Medical Advances and Health Interventions Will Shape Future Longevity. First of all, my name is Andrew Cairns, and I will be chairing tonight's meeting. I'm here in my role as the Director of the Actuarial Research Centre of the IFOA, or ARC. In my day job, I'm a professor at Heriot-Watt University. But as an ARC director, I'm supported by two, or with one vacancy, associate directors, an ARC manager, and three project managers at the IFOA. And one of the ARC director's key roles is to provide support for and to oversee progress on the profession's commissioned research projects. So a little bit more of a brief introduction to the ARC. This was initially launched in 2012. The Actuarial Research Centre was established as a joint project between the IFOA under the steer of its Scottish board and in partnership with the Scottish Financial Risk Academy, SFRA. Today, the ARC is a global network which delivers industry-relevant cutting-edge research programs that address some of the significant challenges in actuarial science through a partnership of the actuarial profession, the academic community, and industry. The ARC's current research programs involve partnerships with institutions and organizations in North America and Europe, and the IFOA is committed to further developing the ARC's internationally relevant program of research to maximize the impact and benefits of that ARC research that ARC research will bring to the global actuarial user community. Apart from the big health research program that we will hear about tonight, current major programs also include modeling and management of longevity and morbidity risk and optimizing future pension plans. A brief introduction now to the research program covered in tonight's sessional. Its full title of the research program is The Use of Big Health and Actuarial Data for Understanding Longevity and Morbidity Risks. This collaborative program seeks to develop novel statistical and actuarial methods for modeling mortality, modeling trends in morbidity, assessing basis risk, and evaluating longevity improvements based on big health and actuarial data. The research program objectives has the following aims: identifying and quantifying the key factors affecting mortality and longevity, such as lifestyle choices, medical conditions, and/or interventions, and we'll hear some of that tonight. Modeling of temporal changes in the factors affecting morbidity and mortality. Evaluating plausible scenarios in mortality trends due to particular medical advances or lifestyle changes on the population of insureds or of relevance to the actuarial community. And lastly, developing tools to forecast the longevity risk of a book based on realistic scenarios of uptake of various health behaviors and/or interventions. And again, we'll have a little bit about that in the presentation. Or on particular disruptions to population health. The multidisciplinary team is led by Professor Elena Kulinskaya at the University of East Anglia, and the program supports 3 PhD students in actuarial science. Now, as a brief introduction to the paper and the presentation, in the sessional, Professor Kulinskaya, the principal investigator, and Nigel Wright on my far left, your right, who's one of the research program's co-investigators, they will discuss the paper, How Medical Advances and Health Interventions Will Shape Future Longevity. The paper and the presentation show how estimated mortality hazards can be translated into hypothetical changes in life expectancies at the individual and at the population levels. Typical calculations are illustrated by 2 examples of medical interventions and their impact on life expectancy, which are beta blockers in heart attack survivors and blood pressure treatment in hypertensive patients. The second example also illustrates the dangers of applying the results from clinical trials to much wider real-life populations. So a couple of brief introductions so that Professor Elena Kulinskaya in the middle of the table. She is the principal investigator for this ARC research program. She is a professor of statistics at the University of East Anglia. And on your far right, Nigel Wright is a co-investigator for this ARC research program, and he is an actuary working in the life data science team within Aviva and is also an honorary senior lecturer at the University of East Anglia. So with that, I would now invite Elena and Nigel to do the presentation.
Thank you very much, Andrew. First of all, I wanted to thank the organizers for inviting me to the beautiful and very sunny Edinburgh, and of course I'm very excited to be in this beautiful old building and to talk to you. As you heard, I will start this talk today, and at the end I hope that Nigel will help me out. So really, my talk today will be about how to quantify longevity changes due to various medical advances. We all know that both medical and social advances are the main drivers of increase in longevity. But the issue is, how can we say how much exactly particular medical intervention may add to the lifespan of the population or an individual? And in medicine, in principle, when something new is being introduced, first of all, there are not one but several so-called randomized controlled trials which are trying to see the effect of a particular new medical advance. Randomized controlled trials basically have, say, two arms. They will be an arm with a new treatment, an arm with a current standard treatment, and patients will be randomly assigned to those two arms. And because of this random assignment to the two arms, the idea is that randomization takes care of all possible biases, and any difference which we can see between the arms is due exactly to treatment. So these randomized control trials are considered to be the gold standard in medicine. However, eligibility for randomized control trials is usually very, very limited to people who have this particular condition but no other conditions. And there are pretty other very restrictive selection criteria there. Another problem with randomized control trials is that they are usually of a short duration. Usually the funding lasts between, say, 3 and 5 years at most. So no one, after a clinical trial, usually doesn't know long-term consequences of the medical interventions. Anyway, if the randomized control trials show that the treatment works, the next step would be to incorporate this medical advance into practice. And after that, in UK, it will be, say, NICE who would decide that this treatment will be available on NHS. And after that, we would need a lengthy lead time to observe effect of this new intervention on population longevity. So we are trying to make this this last step kind of quicker. That's really what this is about. So what do we do? First of all, we have a large database of primary care data, which is called the SIN, or the Health Improvement Network data, which I will tell you about on the next slide. What is important is that we have the data at the individual level. So for each particular patient who comes to see their doctor sometimes over the whole lifetime of that patient, we see various conditions that patient have, various drugs that patient can take, and so on. And we can actually model both the uptake of medical treatment and the effect of that treatment on longevity given particular individual health factors, socio-demographic factors, and so on. Usually, we would be using survival models, such as the Cox regression, which I will tell you a bit later about, and we will fit it to individual level data. And the conclusions from this large population-based data are generalizable to the general population. So, a bit more about the SIN data. This is anonymized electronic primary care medical records. The data collection started in 2003. It covers 11 million patients, currently 3.7 active patients. The data is collected over 562 general practices, covers approximately 6% of the UK population. It is considered to be typical of the UK population after adjustment for various social demographic characteristics. And what comes into the data is all the diagnoses, all the prescriptions, consultations, blood tests, some lifestyle factors such as alcohol uptake or smoking, BMI, also some socioeconomic factors such as deprivation, for example, or sometimes air and water quality, racial composition within a postcode, that kind of thing. So in our research, we are using a particular pretty large subset of SIN, and that is the data on everyone who was born before 1960 and followed up to the 1st of January 2017. And this comprises 3.5 million patients. We added 3 socioeconomic status variables: index of multiple deprivation, Townsend score, and mosaic. I'm sure that many of you know about mosaic because this is a consumer classification by Experian, which is pretty popular in insurance-related modeling. And index of multiple deprivation, say, is more popular in government-based social sciences, that kind of thing. So I'm going to start from our first example on the beta blockers for after acute myocardial infarction, and I'm going to talk you through various methods we're using based on this example. Acute myocardial infarction is a heart attack, and there are 188,000 heart attacks in the UK each year, so it's quite a few of them. Survival rate is about 7 out of 10 people, and because of that, we have more than 900,000 people in the UK who survived a heart attack, and there are roughly twice more males than females. So this is quite a large subpopulation of people who survived heart attack. So the research question, which was actually part of the research by my PhD student, Lisanne Gitzels, whose name you saw on this first slide, was what are the survival prospects associated with the history of a single or multiple heart attack in the general population at various ages, and how can survival prospects be modified by various treatments. So we published this paper in BMJ Open last year. It's open access, so if you're interested, you could look it up. And I'll start from telling you about the results of that paper, that is a medical paper, and then we'll talk about translating it to the things of interest to the actuaries. First of all, how was that study on heart attack designed? It was population-based retrospective cohort study. It was not current slice of the SIN data, but our previous subset of SIN, which was a bit smaller, and that covered people which were born between 1920 and 1940. And that data stopped in 2011, in May 2011. Our main risk factor of interest was heart attack. The intervention we are going to tell you about here is beta blockers. which is only one of the possible treatments after heart attack. We did look at others, and I will mention them very briefly as well. So we looked at the 4 cohorts of patients who have had heart attack before target ages of 60, 65, 70, and 75. And we have chosen those target ages exactly because those ages are kind of important for retirement planning. So, for example, a person who has had heart attack comes to buy an annuity, and how should we price that annuity? That was the question. So what we have done also is we matched cases to 3 controls from the same sex, year of birth, and GP practice. We have done that because, especially in the young ages like 55 to 64, say, heart attack is not very widespread event, luckily. About 6% of males and about 2% of women have heart attack. So say if we look at a woman who have had a heart attack in the early age, 98 women won't have had a heart attack. Basically, we don't want 98 women in our study because they would just cause too much noise. What we want is a pretty balanced study which has a ratio of cases to control, say 1 to 3, because this would allow us to look at it in much more detail, and also it won't lose any efficiency, basically, power in our statistical analysis. We are very keen to match on the people from the same GP practice because we discovered that GP practice means a lot for your health and longevity. There is a very strong effect of GP practice, partly because those are people who live in the same conditions, in the same area, have the same ecological, perhaps, characteristics, but also maybe the quality of their GP also matters. And we have followed those 4 cohorts until death, transfer to another GP practice, or the end of our data, which was 2011. Unfortunately, when people transfer out from a GP practice, we lose them in scene. We can't follow them across the practices. So at that stage, cases and controls were censored out. This axis diagram shows how our cohorts were kind of moving across. So here on the x-axis, you will see the years our medical records cover from 87 to 2011. And the y-axis is the ages of our patients. Those 4 yellow lines here are our 4 cohorts, people who have had heart attack before 60, 65, 70, and 75 years old. And you can see that, for instance, for people at 60 years cohort, they would be born between 1927 and 1940, and we will follow them up from 60 until they go through various other ages. And say for people who come to the 70-year-old cohort, they would be born between 1920 and 1940, and once more we would be following them up for a shorter period of time. So what happens actually is that some patients who came here who have had heart attack before age 60 also are part of the next cohort, because if they didn't transfer from their GP practice, they would be part of the people who have had heart attack before age 65, naturally. But some of those first people here would die, some people would transfer to another practice, and we would add here some other patients who have had heart attack between ages of 60 and 65. So our cohorts are not completely independent. They kind of have some of the patients from the previous cohorts, but they also have new cases. Okay, now for those patients, we looked at quite a few treatments which are recommended after heart attack. Coronary revascularization is basically heart surgery. It can be either coronary artery bypass or it can be angioplasty. And also we looked at various drug treatments like ACE inhibitors, aspirin, beta blockers, calcium channel blockers, and statins. We have a lot of confounders which we needed to adjust for, which included sex, year of birth, social economic status, various medical conditions which are listed there, and also some lifestyle factors such as alcohol consumption, body mass index, and smoking status. Actually, in thin lifestyle factors are not recorded very well. So that's where we had more missing data than for medical parameters. And there we needed to use multiple imputation, a multi-level multiple imputation to fill those missing values before doing analysis. So in fact, we have done two different analyses, one for the full cases and one for imputed data. And we discovered that we didn't have much differences between the two, which was encouraging. And finally, our main outcome was time to death. So we are going to do survival analysis on this data. Those are the numbers. This is our 60-year-old cohort. This is the smallest. And we have the largest cohorts for ages 70 and 75. You can see that we have quite high percentage of deaths there, from 19 in the earliest to 24% in the oldest cohort. But what is important, we have quite long follow-up, even though the average follow-up is not that high in the oldest cohort, but maximum follow-up is pretty long in each cohort. So we can follow up those patients for a while. Okay, now I'm coming to a bit of statistics. What we are going to talk about here is the hazards of mortality. And in statistics, we call them hazards, but in actuarial science, they are usually called force of mortality or mortality intensity. The type of regression model I'm going to talk about, which is so-called Cox proportional hazards regression, which is used all the time in medicine, works with those hazards. So for a hazard or force of mortality mu for patient I at time x, Cox model makes a pretty strong assumption. The assumption is that this hazard can be factorized into two independent factors. The first factor, denoted here by mu naught, is the so-called baseline hazard of mortality. And that depends only on age, x, or time. And the second factor is the subject's risk score. And that risk score depends on a number of predictors that betas would be regression coefficients for that risk score, but the main assumption here is that this part doesn't depend on time. So basically the risk is constant over time. And this, of course, is pretty strong assumption, which we can test for, and if it is not true, we can kind of do other things to make our model still work. But anyway, this is the main assumption of the Cox model, and that's why it's called proportional hazards model. Usually, we also assume that this risk score has exponential sort of log linear form, so that we have just standard regression here in the exponent. So the Cox regression actually doesn't look at the hazards themselves. It looks at the so-called hazard ratio, or ratios of the force of mortality between the two subjects, I and J. Suppose we have two people who differ just on one risk factor. and all the rest is exactly the same. Then if we divide, take the ratio of those hazards for subject I and subject J, this baseline hazard will just cancel out. And what we are left with would be a very simple term, which would include this regression coefficient corresponding to exactly this one factor, times the difference in the numbers of that risk factor, that I and that J. From this line on, I would assume that this is kind of a binary factor. So I would assume, for example, that this person has baseline level, say Z0, and this person has next up level of that risk factor, say Z1. So I will end up with this hazard ratio, which looks like this. And as you see, one of the main consequences of our assumption of proportional hazards is that we don't really need the baseline hazard. We can ignore it. It doesn't matter what exactly is the shape of the baseline hazard, because what we are really only interested in is those coefficients for each of our risk factors. So usually we just don't look at the shape of the baseline hazard. And another important point here is that because we put all those various other factors in the model, our term corresponding to the factor Z is so-called adjusted hazard ratio. That means that this is a hazard ratio given that all other risks are already adjusted for, already accounted for by the model. Okay, so now this is what we obtained from our study of survival prospects after heart attack. This slide has two different parts. In the higher part, I'm looking at the hazards of patients who have had heart attack to those who didn't have heart attack, patients to controls, at 4 target ages. And you can see that actually hazard ratio here is very high. The hazard of death for people who have had heart attack is 1.8 compared to people who didn't have heart attack. And this hazard is depicted on this graph, which is called a forest plot. So this is our hazard, and this is 95% confidence interval for this hazard. So looking at this part of the plot, you can see straight away that hazard actually is going down with age, which kind of makes sense because, of course, if you have had a heart attack before age 60, your hazard of death probably is higher than if you have had heart attack by age 75. Basically, the earlier the worse are your prospects. So it does make sense. But even at age 75, it's pretty high. It's 1.45, the hazard of death. It's higher, almost 1.5 times for people who have had heart attack. Okay, now the lower part is looking at comparing heart attack survivors who had or didn't have beta blockers. So once more, people who have had heart attack by age 60 and were prescribed beta blockers after heart attack have reduced hazard of mortality compared to people who were not prescribed beta blockers. And you can see that actually those hazard ratios are, well, roughly the same in all ages. They are about 15 to 20% lower for people who were prescribed beta blockers after heart attack at any age. So it looks like beta blockers would be a pretty beneficial intervention which may increase life expectancy of people after heart attack. And this is a long list of things we adjusted for in this model. I won't go through it. It's written here. So our next question then is how to translate those findings into individual and population life expectancy calculations. Okay, so I'll start from what to do for an individual. So what we are going to do for an individual, we are going to translate changes in hazards into changes from, say, calendar age to effective age. And that would help to explain consequences of various conditions or lifetime choices to, say, insurance clients or to patients in public health, and basically to nudge clients to pursue healthier lifestyle, which is quite important in, say, life insurance or health insurance. So, for example, we could explain that if you lose 5 kilos, you would be 1 year younger or something like this. And already, as you know, effective ages are used in various insurance applications to apply correct rating to underwritten life. Okay, so how am I going to translate the hazard ratio into change in effective age? You all know that actually the survival after a certain age, say between ages, 50 to 85, let's be cautious, can be described by so-called Gompertz survival law. And that Gompertz law is very, very simple. If you look at the hazards and the log hazard scales, that should be log hazard, sorry about the typo here. Log hazards under the Gompertz law are just linear. They increase linearly every year. And usually the slope of this line is approximately 1.1 currently in the UK. This picture here actually shows you that this is true. This is how actually log force of mortality looks in the UK based on 2010 period life tables. You can see that they are pretty linear, both for males and for females. And we are going to use this very simple Gompertz law to figure out the change in effective age. So suppose we have a person at age X who didn't have heart attack. Then their log hazard of mortality would be something here. But if they did have heart attack, their hazard increases. We know the hazard ratio from our model. And then they have a higher log hazard of mortality around here. Now, we can translate this increase in the hazard into a risk for someone who didn't have heart attack. That person here would have exactly the same risk as the person here who did have a heart attack. But this person would be older. So this is how we are translating this increase in the log hazard of mortality into increase in effective age. Basically, we translated it from this axis to that axis here. And this is a very simple calculation because we can just take log hazard ratio divided by log of our slope, and we get extremely simple formula, log hazard ratio times 10. So this is how much we increased effective age due to heart attack. And of course, if we look at something like beta blockers, we would be looking at decrease in effective age after heart attack. This is how log force of mortality for heart attack survivors looks with and without beta blockers. So here I have 4 plots for 65 and 70-year-old females and males. And the black line here is hazard of mortality for people without heart attack. Compared to it, this blue line is the log hazard of mortality for females, in this case, who did have heart attack. As you can see, the hazard is higher. But when we look at the women who had beta blockers, this is the green line, which is lower than the blue line, even though it's higher than the black line. And what is important here, you can see that actually those lines seem to be pretty linear, so we could apply Gompertz law for our calculations of effective age. So, those are the results of our translation. If at age 60 a person have had a heart attack, their effective age is increased by 5.8 years. Okay? And because the hazard diminishes with age, if they have had heart attack at age 75, their effective age would increase by 3.7 years on average. There is confidence interval here as well. But if those people were prescribed beta blockers, their effective age would be diminished by 1.8 years for this particular patient at age 60, or by 2 years at other ages. And this is the total. Those are effective age changes for people who had both heart attack and beta blockers. So you can see that this is much better than that. We did manage to save about 2 years of life of effective age. The same is true for women. So as I said, those calculations apply for individual patients, but we also want to know what happens at the population level. So, what do we do for a population? Suppose we have a population of a heart attack survivors, and this life expectancy actually is a weighted average of 2 life expectancies, one for people who did have beta blockers and one for people who didn't have beta blockers, 1 and 0 here. But the weights in this weighted average are exactly prevalence of prescription of beta blockers at that age. So if, for example, we have 60% of people prescribed beta blockers at age 60, we would put 60% here and 40% there. Now, looking at this equation, what we really want to do, we want to split this life expectancy, which we know from the period life table, into those 2 components. And this is easy to do, especially if we have Gompertz distribution, because we know the prevalence, we can figure it out from our primary care data, prevalence of prescription. As I said, we know this. And we know also the hazard ratio, so we know kind of the distance between the 2 straight lines. So there is only one parameter we don't know in this equation, and this is the intercept for the first black line. And we can very easily find this intercept from this simple, even though nonlinear equation. So after that, we would know life expectancy of people with and without prescription of beta blockers. And after that, we could play with various scenarios. For example, we could say, suppose prevalence of prescription of beta blockers grows from, 60% to 80%. What will happen to population life expectancy? And it would be very easy to figure out. So that's the idea. Of course, we first need to come up with prevalences. And here we can see prevalences for different treatments which are used for people who have had a heart attack. This black line here, for example, is statins, and the red line is aspirin. And you can see that by 2010, practically everyone who have had heart attack would be prescribed both statins and aspirin. So increase in life expectancy due to those two interventions is already incorporated into life expectancy, and we won't get any more out of this. Now this blue line here is beta blockers, and you can see that actually beta blockers by 2010 are only at a level of about 60%. So here we do have some scope of increase in life expectancy if everyone is prescribed beta blockers after heart attack. And actually this fact was picked up after our publication of that paper I mentioned to you. There was a review about it in the Journal of Hospital Medicine, which kind of told the hospital doctors, please do start prescribe beta blockers to everyone, because that seems to be very good. Okay, so how exactly would prescription of beta blockers affect population life expectancy? This is the result of our split of life expectancy. This is overall life expectancy at age 60, 65, 70, and 75 here. This is life expectancy of people who have had heart attack. To do that, we kind of split this overall life expectancy into two components, people with and without heart attack. So you can see that people who have had heart attack lost about 4.5 years, or is it? Yeah, I think 4.5. Okay, and then we split this life expectancy for people after heart attack further into those who have had beta blockers and those who didn't have beta blockers. And you can see that once more there is quite a bit of difference between those who had and didn't have beta blockers. So now we can, as I said, play with different prescription prevalence scenarios. For example, that life expectancy would be there if we didn't have any beta blocker prescriptions. And that life expectancy would be there if we had 100% prescription. Okay. And now I'm very briefly introduce a second example, which is about intensive systolic blood pressure control. There was a very influential trial in the United States, which was looking at intensive blood pressure control, and which was stopped early because it appeared that people in one of the arms had much more benefits out of intensive blood pressure control. So basically the current guidelines in the US, not in the US, sorry, at that time in the US and currently in the UK, is to keep blood pressure control at 140 millimeters. We're talking about systolic blood pressure. And in the intensive arm of the sprint trial, they tried to keep blood pressure instead at 120 or below. And as I said, it looked like it really had good results both for various morbidity and also for survival. Even though they did have quite a few adverse renal outcomes for people in intensive arm. Anyway, that trial was so impressive that the American Heart Association changed its hypertension guidelines just last autumn. And now in the US, everyone who has a systolic blood pressure of 130 or more is considered to be hypertensive. And they would be first try to be treated with lifestyle interventions, but then they would be put on drugs starting from 130. In the UK, the guideline, current NICE guideline, is still 140, but NICE is currently looking at a revision of its blood pressure guidelines. So what we wanted to do when we saw the sprint results is to see how our primary care data supports this beneficial intensive blood pressure control. So what we have done, we tried to imitate the sprint design. So we found almost 55,000 patients in SIN, aged between 50 and 90 years, treated for hypertension between 2005 and 13, and followed up to 17. And basically what we wanted is people who already had hypertension, but which was out of control, which was above 140. And then we wanted a new prescription for them. And in a result of that prescription, some people would drop blood pressure to under 140, and that would be our control arm. And some people would drop blood pressure to under 120, and that would be our intensive arm. And we then tried to see how those two different scenarios kind of resulted as far as longevity and various adverse outcomes were concerned. So, results. As I said, in SPRINT, they had very, very beneficial result in the intensive treatment arm. They got a hazard ratio of death of 0.73. That means that there were much, much smaller hazards of death in the intensive treatment arm compared to the standard treatment. And this is pretty big change. So that would lead to a decrease in effective age of about 3.5 years. And because of this new American Heart Association guidelines, the question arises whether we are to wait the boost in the life expectancy in the US in the next several years. Our answer is no, probably not. Because when we looked at the SIN, we found actually that the treatment wasn't beneficial. It appeared to be harmful. Our intensive patients had increased hazard ratio of death of 135, which would translate into increase of effective age of 1.7 to 1.8 years. And in both studies, the more intensive was the treatment, the more drugs you would have, or the higher doses the patient would have. All those things would increase both the hazards of mortality and also the hazards of adverse renal outcomes. We also looked at the baseline hazards for the SPRINT study. And here, we got pretty strange shape for the hazards. If you look at those pictures, you can see that it appears to be pretty linear up to about 8 years, but then it starts to be kind of dropping a bit. And actually, the question is why? And I know two answers. The first answer, which came first to my mind, is that many actuaries are familiar with this kind of shape of hazards when you look at the survival of the oldest old after 90 years and older. There you can see this kind of shapes. And usually that is explained by heterogeneity. Sort of weaker people are called out first, and by the time you get to over 90, say, you are dealing with a particular genetic subpopulation which really have very good genes and can live kind of forever. Okay, so this is one explanation, but then I realized there may be another explanation here as well. Because when we were selecting those patients, remember, we selected people who had hypertension, but they came to their doctor and they had further intervention and they dropped the blood pressure. But there were quite a few people who wouldn't go to their GP, or interventions there may not be successful. And you don't see those people here. But it may well be then for those people, the hazard actually went up, so that on average we did have Gompertz law, but we had kind of a pretty benign subpopulation here, people who did do something about their blood pressure. So anyway, this requires more research to understand what exactly is going on here. And I think I now told you everything I wanted to, and now I'm very happy to pass the mic to Nigel.
Thanks, Elena. I'll try and get through this quickly so you've got plenty of time for questions. So just to summarize, I won't go over why you might want to estimate longevity. Everyone's got their reasons. And I guess that's why you're here rather than just trying to top up your CPD before the end of June. So modelling mortality experience in individual level health data from large databases can establish and quantify drivers of changes in mortality and help to predict how those changes may change over time. And we've shown how you can change that into individual and population level life expectancies. If you've got a model that allows differences in the prevalence and treatments within the population, then you can transpose results so they apply to a subpopulation that you're interested in particularly. For example, if you've got insured lives or a particular pension scheme, you can allow for what you think are the prevalence of treatments within that subpopulation, which addresses the question of basis risk, which Andrew mentioned was part of our project brief. So in the paper, it's give an example of how you can do this using hazards of mortality associated with risk factors you're interested in, the prevalence of those risk factors, and an underlying life table for a population. It's a fairly simple method, and really how you, if you want to do something more complicated, then the aim is that the project will produce stuff that you can do more complicated calculations if that's what you feel you need. So changes in the prevalence of the risk factor of interest are reflected in the life expectancy of the population at the population level, so you can see how much the factor of interest has already contributed to changes in past longevity improvements. So for example, if you see that in the example, if aspirin, say, prescriptions are now pretty much 100%, then you're not going to expect increased longevity improvements as a result of that. But then also you can see how continuing trends of prevalence of the risk factor can influence future life expectancies. So yeah, the approach can look at the prevalence of known treatments or conditions. It's never going to provide a complete answer, of course, because you don't know what's going to go on in the future in terms of new conditions, new treatments. So it's for all that, you can still use it either for projecting, saying questions like, are you past the past peak of mortality improvements resulting from treatments that you know about, for example, beta blocker prescriptions, and you can see how much more mortality improvement, longevity improvements you could expect from beta blockers. And you can also answer questions like, if you're wanting to maintain a particular trend in mortality improvement, then you would need a medical advance of a particular size, and you can kind of give a comparison. So you need something as big as statins to come through in the next, so however long, in order to maintain a level of longevity improvements that you're interested in. And you can answer questions like, what would be the impact of another medical advance, the size of statins. So as we said, this paper comes out of work that's funded by the Actuarial Research Centre. The case studies we've presented here, or Elaine has presented here, are the beta blockers following a heart attack and the effect of intensive blood pressure control. We've also looked at statin prescription, and that's also published in papers that Lizanne and Elena have put together with Nick Steele, who is another academic who's working, he's a professor now, isn't he? Another at the UEA, who's also on the project. And then as part of the project, which continues, the funding continues to 2020, there's a list of medical conditions and health interventions that we're kind of working our way through, so including stroke and type 2 diabetes as well as heart attack, and then health interventions as well as statins, blood pressure targets and things like that, looking at hormone replacement therapy. So to keep yourself up to date and find out more, then did I press the wrong one there? Find out more, you can go to our website, which has got links to various presentations, published articles, even a few videos. Maybe even this will be on the video, one of the videos you can have a look at. I think that's about it. We're at the end of there's a few references. So these are references to the paper. If you want to know more, then go to the website and find out. That's all I have to say, so I think it's over to questions now. Thanks.
My thanks to both Elena and Nigel for your excellent presentation tonight. The discussion is now open to the floor for both comments or questions about the work that they are doing, and the comments that you could make, I mean, it might be related to the presentation tonight, but it could also be more forward-thinking in terms of how you see the results of this sort of research being used in practice in an actuarial setting, because it's very much one of the aims of the Actuarial Research Centre is to not just do the fundamental research, but then to take that through to the application end of the spectrum and develop impact in certainly in an actuarial setting, but also for this project, for example, there are other types of impact that we would like to see as a possibility, which is, for example, the health guidelines and through the National Institute for Clinical and Health Excellence, if that's the right. Although the H disappears when you get to the acronym NICE. But anyway, so the developing impact is certainly one of the things, and I'd certainly, and we would certainly be very welcome if people have comments on that. So we're looking forward to an interesting and stimulating debate, and want to encourage as many of you as possible to contribute in the time that's available. Just a reminder that the meeting is being video recorded for publication, not the video, just the words, in the British Actuarial Journal. So please state clearly your name before making your contribution. Also, if you are of less than 15 years since you qualified as an actuary, then you will be also eligible for the Sloan Prize, which is available at every sessional meeting. So if you are eligible, please also state that when you're giving your name, so that we're aware of that. Could I now just briefly just invite anybody who thinks they might wish to contribute to the discussion to let me know of their intention. So if you could just put your hand up. Okay, so there's 3 or 4 people. Okay, thank you. Please wait for a microphone to be brought to you before you begin your contribution, and make sure that you do speak into the microphone. So I think the first question is there in the front row. Oh, go on, there's that. Right.
Hi, thanks very much, really interesting. My name is Nicola Oliver, I'm a longevity mortality consultant. My question really relates to the increase in so-called multimorbidity, where somebody has 2 or more conditions, and in particular the increasing concern around polypharmacy, because of course, as you mentioned, the RCTs are the gold standard for assessing effectiveness of a treatment, but of course those trials were undertaken on people who were not taking any other medication, and increasing evidence around the effects of one treatment against another. And similarly, a comment really about people who are not taking beta blockers. There's often concerns by patients in terms of unpleasant side effects. And are there other illnesses that those people have that prevent them from taking, say, a prescribed beta blocker or a statin? So just really thinking about the impact of other treatments, not just illnesses, but also is there any possible way of being able to account for those issues? Thank you.
Well, you have seen that in our models we have adjusted for quite a few various health conditions, such as, say, diabetes or renal disease or cardiovascular disease. We also adjusted for lots and lots of various medications. So we tried to take all this into account, and that's exactly where the primary care data is very helpful. Of course, what we cannot do, we know the data on the prescriptions. We don't know the data on where the patients are taking those prescriptions. But still, up to that limitation, we do have more or less accurate picture of at least current prescriptions. And what we are trying to do now is try to not, like this design I was talking about here was actually kind of a design where we looked at, say, whether people were prescribed statins by a certain age, for instance, or whether they had heart attack by a certain age. But now we are trying to follow patients over time and see more realistic scenarios like on statins, off statins, and on statins once more, that kind of thing. That will be our next paper to understand what really is going on. Yeah.
Just as a follow-up to that, in the modelling work that you're doing in the Cox model, have you been able to look at interactions between some of the confounding variables and the prescription?
Yes, absolutely. We usually look at quite a few interactions. We start from a very large model which includes all possible predictors and the interactions, and then we kind of doing backward selection, ended up with a model which has only significant interactions and main effects. So yes, we are looking at various interactions of different prescriptions and diseases.
And do you find then that the sort of polypharmacy, so multiple prescriptions, does that actually do you see an impact there?
Well, even in that sprint trial I was mentioning, we did find that last slide, if you remember, that if people have more than 2 prescriptions for lowering blood pressure, or if they had high dosages, yes, that resulted in higher hazards of mortality and also in renal side effects. So yes, of course.
My name's Derek Pike. I'd like to thank Ellen and Nigel and say that I think this type of study looking at specific causes of death is very worthwhile. I've 2 questions I'd like to ask. The first is, did the data allow you to distinguish between patients who'd died of a heart-related condition and those who died of an unrelated condition? It wasn't clear to me. The second question I have is, were you able to consider at all why some patients, only 60% of patients, had been prescribed beta blockers, and you know, if there are reasons why doctors prescribe those 60% and not the other 40%, because you know, if for instance they only prescribe beta blockers to patients who'd had just a mild heart attack or who had recovered well from the heart attack, then you know that might make it inappropriate for you to extrapolate the results to the whole population.
Sorry. I will answer the first question first, and that was about cause-specific mortality. The answer would be disappointing, I suppose, because we do not have causes of death in our data. It was a conscious decision because, of course, the data would have been much more expensive, but also, to be sincere, I don't believe in the cause-specific recording. I think that it's not recorded very well, and, well, kind of everyone dies from pneumonia regardless of what they really have and that kind of thing. So the answer is no, we only looked at cause-specific mortality. Coming to the question why, I think beta blockers is not very interesting in that respect because beta blockers are pretty cheap, and I think mainly it was due to lack of knowledge by hospital doctors. That's why our work was picked up by the Hospital Medicine Journal. But there are much more expensive interventions, of course, such as, say, heart surgery. And there we looked at who is getting intervention and who doesn't. And there is a pretty clear social economic component, there is gender component, women have much more than males, for instance, and so on. So yes, usually every new intervention, when it only starts, is being delivered to people sort of at the top of socioeconomic status, and then it slowly sort of goes down to the other levels.
Thanks, Ian McClellan. Two quick questions, hopefully. Just interested, I'd not really been aware of the thin database, and interested in terms of how that's grown over time. Do you see more practices, etc., adding to that data set, or do you see challenges there in terms of people getting more concerned about their data in the wider sense and looking to be opted out, or not have that information shared? And second, the more practical question is, I think to the point Nigel made at the end, in terms of being able to look and think about what if we had statins Mark II or some other type of intervention. Based on your modelling, what kind of timescales do you think from whatever that new treatment starting to be recorded, would you be able to get sort of credible and significant results that you could start to answer those kind of questions? Is it always we'll need 20 years worth of data here, or is there a point at when after only a few years, if the data set's big enough, we would be able to make some of those sort of more definitive statements?
So on the second one, I suppose if you're looking at longevity stuff, then you need long enough for people to have died. And particularly if you're looking at something that's improving longevity, you need to have long enough so you notice that they haven't died, which takes even longer. But you can see examples of the take-up of different medical interventions, medical treatments. In the graph that Elena had earlier on, that different things take different times to come in and people to realise how good they are and the take-up rates, and so you can look at different gradients for those take-up rate graphs. I mean, there's other stuff that you can look at, as Elena was saying. If you've got differences by gender or by age or by socioeconomic factors, you could also see how that comes in. As to access to the thin data set, I'm not sure if I should pass that over to Elena to say.
Well, I'm sure that you are aware that insurance has very bad image as far as access to health data is concerned. And so we did have some problems in obtaining the data. I have to say that we had two different subsets of thin over time. We started from the first subset, which was people between 1920 and 1940. And I have to say that it was much easier to obtain that data than to obtain data for this project. Because between those two dates, there was that scandal by whatever it was, Sun or something about, bad insurance companies using our health data. Yeah. So yes, it is pretty difficult, and we keep hoping that it will improve, because personally I don't see why pharma companies would have any better reputation, but it's yeah. It appears that it is easier for them. Many health data providers specifically state on their website that this is only available for health research, and strictly speaking, insurance research is not health research. So yes, it is difficult, but not impossible if you persist.
Thank you very much, Elena and Nigel. Very interesting talk. My name is Helen Chung-Patterson from the University of Edinburgh. You mentioned RCTs at the beginning, and I'm interested about other forms of more conventional medical research, of the other kinds of studies like long-term prospective cohort studies, and interested to know whether you found any comparable age-matched data among, say, post-marketing surveillance studies or any long-term prospective studies, to compare whether you were getting a similar ballpark of hazard ratio compared to the retrospective matched work that you've done. I think it would just be interesting, because those studies have been around from before big data became so popular, and if they were similar, it might in some way actually increase the credibility of big data in a more traditional audience. And if they didn't match, it might raise interesting questions about why they didn't.
Yes, thank you. This is an interesting question, and we did look at other sources of data. There are several interesting studies. For example, there is a so-called ELSA, English Longitudinal Study of Aging, and there are other kind of traditional studies. The issue with those studies is that they are very well designed. So from that point of view, they are much less prone to various possible biases than primary care data. On the other hand, they are unfortunately very small as far as I'm concerned if you look at some health condition which doesn't strike everyone. Like, for example, when you look at dementia, there were recently several papers which were published about dementia from ELSA, say, or I forgot there was another study like that. And really, the sample sizes they work with is about, 500, 700 cases. This is certainly not enough to build a proper model, as far as I'm concerned. So, on the other hand, I'm very enthusiastic about the primary care data, which is kind of a big data, but yes, we do have lots of various issues, and it does require quite a lot of attention to design of a study to be able to get rid of at least major part of possible biases in this data.
My name is Andrew Scott, and I'm not an actuary, I'm a civil servant, and I'm the Director of Population Health at the Scottish Government, where I'm responsible for public health and primary care and mental health. And just a couple of questions, really. I don't quite understand all the details of the actuarial modelling, but a couple of things struck me as relevant. Firstly, what do these studies and other related studies tell you about how you might influence medical practice? Is there something you might do to improve the image of the insurance business by changing medical practice in some way and applying this data differently? And secondly, if you were to think, one of the things that I'm responsible for creating is the new body, Public Health Scotland, which will hold NHS data for everybody in Scotland. And I wonder, what is it you would do to improve the quality and reach of health data in Scotland if you had an opportunity to do so? Thank you.
You're looking at me, aren't you? So yeah, I mean, in terms of influencing public health as well as providing stuff for actuaries like me who just work in an insurance company. So in the project team, we have Nick Steele, who's a medical doctor as well as being an academic doctor, and using insight that he's got as some of the results we've been coming up with, as Elaine said, have been publishing stuff in medical journals as well as this sort of thing, so hopefully helping to guide the beta blockers, for example, prescriptions. What we're finding on the comparison with the SPRINT trial, feed that into decisions about treatment of high blood pressure, what counts as high blood pressure. In terms of improving quality and reach of data, I think one of the main problems that we've had with Thin is that it's GP stuff, and we don't really know what goes on in a hospital. And so there doesn't seem to be much of a link between what the GP records when you go and see him in a surgery and what happens at a hospital. You'll see that they're maybe sent out to a consultant at a hospital, but in terms of what gets recorded and what we can see in Thin, there's often a big gap. So in the list of conditions we were looking at, you'd want to put cancer in there, but cancer in the Thin data sets, it's pretty problematic because most of the cancer care that goes on will be going on at a hospital. And so you might know that the doctor had concerns about cancer and sent you off to a hospital, and what you get back and gets recorded in the Thin data set is patchy at best. So I think linking stuff up, and I think that's people in the health service know that the linking between different parts of the health service.
Yes, I enthusiastically support this answer. I think that the main issue for any health research and for our research as well is exactly good linkages between different health data sets, because for cancer, for instance, even hospitals don't have good data. I know I did work with hospital data as well. It's Cancer Register who has good data on cancer. So what we really want is a link between primary care, secondary care, and specialized registers such as Cancer Register, National Joint Register, and any other registers. And that would be really nice if you could achieve that. I personally would be thrilled to work with Scottish data if you can do that.
So that's the second bit as well, is having done all that linkage, you have to let Elena have the data.
Maybe just to follow up on that very briefly, and then we've got another question there, that in terms of the primary care data, are there things that could be improved within that? So, for example, in your presentation, you mentioned that things like body mass index or smoking is patchy. So how much do you think that your work could be improved if that particular aspect of the data, the primary care data, was also improved? And well, a sort of follow-up maybe for Mr. Scott would be, how easy would it be to actually improve that to a reasonable level?
Well, I did mention that we used a pretty sophisticated multi-level imputation methods to try to ameliorate this problem with the Thin data. Actually, recording of say smoking or BMI in primary care quite improved when there was a quality outcomes framework introduced because doctors started recording it much more consistently. Still we had, I don't remember off the top of my head, but like 25% of, say, BMI data missing. So it is quite a big proportion of the data. So of course it would be much better if it were recorded. I don't think that we can improve the quality of the data just by, legislation or good example. Usually it is improved due to changes in payment, from my experience, yeah.
Is this live? Douglas Anderson of Hyman's Robertson and Club Vita. I'd like to kind of continue this theme, if I may, of big data and how things might become more useful to insurance companies and risk takers. And it kind of strikes me that if you've got to wait what seemed like quite a long time for people to pass away, the data becomes, some people would argue, the data becomes a bit stale before you get round to using it. So wouldn't it be better, I'm just wondering whether it would be possible within the constraints of this data set to look at changes in morbidity over time, so that if somehow you could describe the typical pathway of a patient treatment, and you could like put a series of milestones that you have to go through on that particular patient trajectory, but could say how quickly, could measure effectively how quickly you get from A to B to C to D, and see whether those are changing as you kind of follow this longitudinal data set through, and then hook it all up so it works in real time, and you don't have to wait to publish a paper, but you can just, you know, stick the results up on the internet for us.
Well, yes, we, and not only we, other people as well, look at modeling different health states and trajectories of patients across those states. We are thinking of modeling, for example, morbidity due to diabetes. And there we exactly are thinking about doing different states because, as you know, diabetes would cause various cardiovascular morbidity and other complications and so on. So we might end up with doing this kind of analysis with multi-state model. Yes.
And that's, I think that's often what the sort of thing that drug trials will look at. They'll look at effects on blood pressure rather than on your eventual death. So they'll say, this is to treat blood pressure. And I mean, blood pressure is just a number, really. It's not, it's kind of indirect. What you'd really be interested in is quality of life and life expectancy. So they're using that as a kind of interim measure. What you have to be careful, though, is if there's side effects that were going to come through, so that you might have fine blood pressure, but then if it's damaging your kidneys, then your pathway to death will change. And it'll no longer go down the kind of blood pressure heart attack thing. It'll go down the kidney failure death pathway. So yeah, it's not going to provide the whole answer.
Okay, so we have time for one very brief question, hopefully, but over to the front row here. And then we'll wind up for the evening.
Thanks. Terry Maxwell, your presentation clearly showed the benefits of beta blockers for those that have had heart attacks. Is there any information to show the benefits of starting on beta blockers before having your first heart attack? And more generally, is it possible to get hold of data to investigate the preventative effects of treatments rather than having to wait till somebody's already had a serious event and hence investigate the effects of preventative medicine on longevity?
Yes, absolutely. First, to answer your first question, beta blockers do not have any effect of people, at least on longevity of people who didn't have heart attack. Zero. Okay, so that was easy. The second one, yes, for instance, we did look in much detail at the effects of statins. And as you know, with statins, guidelines also changed a couple of years ago. And previously, the guideline by NICE was that everyone who has 20% risk of cardiovascular event in the next 10 years would be eligible for statins. And then that changed to 10% risk. And then there was quite a lot of outcry from the GPs about medicalizing people who were practically healthy and who had just 10% risk of something. So yes, we did look at effects of statin on life expectancy, and our answers were somewhat different from NICE. Basically, we had a qualified answer. At younger ages, like 60 or 65, and low risk, you don't really need statins. There are no benefits. but at older ages, statins appears to be beneficial for life expectancy.
Okay, so we've certainly had a very interesting and varied discussion, as well as a very good presentation before that. So it remains for me to express my own thanks, and I'm sure that all of us here would like to thank the presenters and those who participated in the discussion in the usual way.